goes and whatnot. But in honor of our episode, not that this has anything to do with psychedelics, but it just made me giggle. So I like to light a candle for mood setting, and my
Mm-hmm.
candle is out of wax. And so I lit incense. So that's what I have in the background. Woo! So I was like, this is really funny because I used to light incense all the time and like meditate, and I got out of the habit. I was like, well, this is the perfect time to start again.
I discovered incense when I was about 14, and I growing up in the suburbs, it seemed very exotic to me. And I lit it in my room, and I think my father came and was like, "Are you smoking weed in here?" Like, no, it's incense. It's very
It is a
bohemian.
little strong. It is a little strong, I must
Well,
say. Woo, it's been a while.
If you start coughing in the middle of the session, I'll know why.
I don't think it'll make me go feel woo. Anyways. All right, Andrew, I'm so excited to connect with you. I know you're a very busy, in-demand person. And I'm just really appreciative that Lynn Marie had introduced us. You came highly recommended by a bunch of sources.
Oh.
And honestly, I had decided to do an episode on psychedelics. And then I started talking to some folks, and I realized there's no way that I could cover this with justice in one episode. And so it's turned into a 3-part series. I really appreciate you making time.
Yeah, my pleasure.
So before we dive in, why don't you tell us about yourself and how you got into this field and what you're doing within it? Because I do think it's so unique and interesting. So please share that with us.
Yeah, sure. My name is Andrew Penn, and I'm a clinical professor at UC San Francisco in the School of Nursing. I'm trained as a psychiatric nurse practitioner. I did that about 20 years ago now, which is wild to think. And I divide my time between teaching in the School of Nursing. I teach advanced practice nursing students, so people that are going to become psychiatric nurse practitioners. I work at the San Francisco VA doing clinical work and overseeing residents there. And I also spend part of my time doing research on psychedelics. So that's a very interesting and very robust area right now. Worked in the past on the MAPS-sponsored study of MDMA assisted therapy for PTSD, and also on the USONA-sponsored study of psilocybin for major depression, a single dose of psilocybin for major depression. And more recently, I've been working on some small trials that we're doing in our lab, looking at people with bipolar 2 disorder who have depression, treating them with a psilocybin intervention. Also recently completed a small trial of people with depression and Parkinson's disease, which was so we're looking to see if we can do that safely, because the two studies I just mentioned, the bipolar study and the Parkinson's study, are important. Even though they're small studies, those are two groups of people that have largely been excluded from trials to date. And so we want to see if we can begin to see if there's evidence for safety in those populations as well. And then we're getting rolling on a study of people with chronic low back pain, and are gearing up to do a study of young adults with anorexia nervosa, all of which we're addressing with a psilocybin assisted therapy intervention.
Wow. I mean, this is honestly just such a fascinating topic for me. I know that Michael Pollan has written about psychedelics, which I think has helped people, I guess, make it feel more mainstream, so to speak. And by the way, I did not want to interview him because he might not have even said yes, but nonetheless, because he was coming from a journalist perspective, and I really wanted to come from those who are practicing. And again, not to say he's not credible, but the way I tend to cover things is more from the researchers.
Michael's book.
Go ahead.
Is
were you
really,
going to say something?
Well, I was going to say Michael's book. If we had to pay Michael $5 for every person who found our studies because of Michael's book, we would have to increase our budget substantially. I mean, really, he has put the word out there about this, and it's appreciated because it's definitely helped. I think a lot of people who didn't have a closer understanding of this understand it better. It's also been challenging because it creates it's added to the hype around this, and there is a lot of there's a lot of hope and a lot of hype around this space right now. And part of the challenge, especially for somebody who is new to it, is sort of separating the wheat from the chaff. But even for those of us who've been in it for a while, we're finding that many of the subjects who come into our lab have real big hopes for this, which I understand because we don't have the treatments that we have right now for a lot of mental health conditions are not as effective as we would like. So I fully understand the need for better treatments. It's just we're still in a very early stage of this. So there's a lot of things that we just don't yet know. And that's just the nature of science. That's okay. That's why you do science, is to try and answer those questions. But in the absence of data to answer these questions, we're finding that a lot of people are engaging in kind of rampant speculation, and that's creating a lot of challenge and a lot of sort of noise in the space. It's difficult
Right.
to cut through sometimes.
Yeah. So then I guess what I would love to start, and I actually thought about asking this question, and the way you put this, I'm like, heck yes. And it's not a big deal. It's just like, what is it that people aren't talking about but should? Because just I guess going off of what you said, and feel free to react to what I'm about to say, or the question that I had is, what is it that people aren't talking about that they should be talking about? Because I know that people are excited, and I remember now is like when things are out there, especially now with social media, people pick up on it, and we're in this quick fix society where we're not really diving deep into things, and we're making a lot of assumptions. In light of kind of that tone, what is it that you want people to know that we're not discussing, especially for those who are more on the open-minded, I'll try anything side, perhaps because of fear and desperation in trying to get help?
Mm-hmm. Yeah, I certainly understand the motivations for being interested in this. As was mentioning a minute ago, the shortcomings of the current mental health system leave a lot of people either untreated or undertreated. They're partially treated, and they might feel better but not well, and that's an important distinction. I think where there's some challenges in the messaging around psychedelics, I think there was this early notion that this could be sort of a one and done treatment. That you hear this phrase, "Oh, it was like 10 years of therapy in one day," and I
Yes.
really think that's overpromised on a number of
Okay.
different levels. Um, so the data that we're seeing right now regards to the durability of the effects of the treatment, they vary. But the reality is probably this is something, if we look at something like psilocybin for major depression, the durability might be 6 months to a couple of years.
Okay.
And then the person would probably need to be retreated. And in the early studies that we saw of this, we were seeing people who would go several years out and still say they didn't feel depressed, which is great. And there will
Okay.
be people like that, but I'm not sure that's going to be the average response. So I think one sort of myth to unpack is this idea that this is one and done and curative, and frankly, I was part of that hype at the beginning too, because in our very early studies, that's what we were starting to see. But the nature of doing clinical trials is that you start with a very kind of cherry picked group of subjects who are
Right.
likely to be able to, that you can treat them safely, and that they're kind of ideal patients in some ways. And then as you get into larger studies, what we call phase 3 studies, it's more representative of what real patients look like. It's still not perfect because there's a lot of things that we exclude people from that have complexities, like other medical conditions, other psychiatric conditions, comorbid substance abuse. So we exclude those people from phase 3 studies usually, but that's who represents our real world patients. And so
Right.
there's always this challenge in sort of translation of, are you going to get the same benefits with the people in real life that you got in the clinical trials? And we've seen this time and time again in psychiatry. When SSRIs first came out in the 1980s, people talked about curing depression, because in
Right.
clinical trials they were so robust. And then we bring them out into the real world and we give them to people who have, medical issues, or they have an alcohol use disorder or what have you, and they don't work as well. Um, and then there's this, we're very we run very hot and cold with things in this country. So, what the thing that is a miracle cure today is a disappointment tomorrow.
Yep.
And, I think we might be sort of heading towards that with psychedelics, because I think not because they're not going to work, but I don't think they're going to work as well as they are sort of currently promised.
Got
And
it.
and the way that they will work is going to be different than what we're used to. And I think this is an important thing to understand, is that a lot of our treatments that we use right now, say common antidepressants, they are effective for some people. It's very fashionable in the psychedelic space to kind of make a straw man argument about SSRIs and talk about how, there's not many of them and they don't work very well. And there's certainly some truth to that, but they do work very well for some people. And we're going to need both. We don't need to eliminate one with the other. What we need is more treatments, not fewer treatments in psychiatry. And so this will be another option, hopefully. But the way that they work, the way they affect this change appears to be somewhat different, in that things like SSRIs generally tend to kind of blunt negative emotions. And they sort of turn down the volume on anxiety or depression. The downside is they tend to turn down the volume on other emotional experiences as well. So people on SSRIs will say, well, I don't feel as depressed, but I just don't feel as much of anything. I used to
Right.
cry in sad movies. Now I'm just finding myself not feeling it. And so there is this challenge with them, is that they sort of dampen people's emotional experience, which, if you're depressed, is not necessarily a bad thing, but it's different than how psychedelics work. So
Yep.
psychedelics tend to be, sometimes the term is non-specific amplifiers. And so they turn up whatever happens to be present right now for the person. And
Okay.
so they tend to take somebody's emotional experience, and when they're when they're used in this more therapeutic setting, they often are really that person will be confronted with whatever it is they're dealing with, and that often gives them an opportunity to work through that, to feel more confidence in feeling those feelings, because we spend a lot of time as human beings trying to avoid feeling what we are feeling, something called experiential avoidance in the psychology
Right.
literature. And psychedelics are really counter to that. So they really tend to amplify whatever emotional experience the person is having. And this is one of the reasons why good preparation is so important. So before, just to be clear for people that have not heard of this work before, sometimes people ask me, well, I just go down to Walgreens and get LSD? No, 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 no. So what we're looking at here is a model where this is really a psychotherapy model that is catalyzed, amplified, if you will, with the judicious use of a drug 1, 2, maybe 3 times. So instead of taking a drug every day, you're having this preparatory psychotherapy process with the therapist, sometimes 2 therapists. Those same 2 people are going to be in the room with you when you take the drug, and you have all day kind of carved out for that. So you got nothing else going on that day. And really, during that dosing day, we encourage people to go inward. So the other misconception a lot of people have is that we're sitting there doing, cognitive behavioral therapy for those whole 8 hours or something. No. Most of the time when people are under the influence of the psychedelic, they're not really talking very much. And in fact, we encourage them to have this kind of inward experience. We provide eye shades. We have a pre-selected set of music that people can listen to really direct their attention inward. The drug will wear off after 5, 6, 7 hours. And then starting the next day, we begin doing this thing called integration, where we talk about the experience that the person had, try and unpack that, look for opportunities possibly for them to change something about the way that they're engaging in their life, the way they're thinking about themselves or thinking about their circumstances. And we might repeat this process depending on the study protocol. In the MAP study, we did that 3 times. In the USONA study, we did it just once. So there are these different models of doing this, but it's just important to understand that sometimes that psychedelic experience, it's not all rainbows and unicorns. It often can be quite challenging. It can be quite beautiful, but it can also be dark. It can be scary. In something like a PTSD study, we get the agreement of the subject. We this is part of the preparation of, if your trauma doesn't come up during the session, can we bring it up? Because we're going to spend some time talking about that. And that's really, really important, because a lot of times people with PTSD spend an inordinate amount of energy trying not to think and feel about the traumatic experience. And so we want to make space for that in this therapy specifically. So those are some of the differences. The other thing that I think people need to understand is that while psychedelics are largely physiologically safe, compared to, say, something like an opiate, which in large enough doses suppresses breathing and you can die from, psychedelics generally have a high margin of physiologic safety, but they can be psychologically challenging. And especially if they are used in settings where people don't have the support of somebody who knows what they're doing when that person is in that state, especially when somebody is taking this in a societal context in which these are against the law, where people can lose their job over this, for example. So that engenders a kind of fear around this, where people who are having a difficult experience might be apprehensive about seeking help for that. And so this idea that these are without any potentially negative side effects, I think, is untrue, and it's misleading people. I think about that recent case of the airline pilot who had ingested psilocybin a couple of days before, and then, when he was on the plane, had this experience of what we call in psychiatry derealization, that things weren't real, and that was his rationale for pulling the fuel cutoff switches on the plane. That was somebody who was clearly having a challenging psychiatric experience that was likely secondary to recent ingestion of psilocybin. Was he on psilocybin at the time? No, because psilocybin doesn't last that long. But he was experiencing some challenging effects following that. And I wonder, might that situation been different had that person had more support and a place where he could talk about those experiences before he had to go back to work. So I think the misconception I want to clear up is that, while these are relatively safe physiologically, they do come with some potential attendant psychological challenges that can be mitigated with good support and a good structure to support that person in. And so you can't necessarily replicate these things by finding somebody who grows mushrooms and taking this on your own. Now, you might. I mean, we haven't tested that. We haven't studied that to compare if the two are comparable. But there's a lot of people who are kind of charging ahead of the science. The culture is charging ahead of the science. Laws are starting to charge ahead of the science. And, as a scientist, that concerns me.
Like which laws that are charging ahead are most concerning to you?
Well, I see a lot of well-intentioned laws around decriminalization. So to be clear from the outset, I think drug prohibition is a totally failed public policy. The idea of putting people in prison for changing their consciousness is bad policy. It doesn't work. That said, sort of letting the floodgates open and letting the commercial sector come, or even the sort of de facto commercial sector come in and offer, say, something very powerful like psilocybin widely without much guidance, or without a culture that has an ability to absorb that. We don't have good messaging around what is a safe setting to use psychedelics in. What is an appropriate dose? How long should you plan for? Those are all public health messages that we need to have out there to go along with something like decriminalization. And there's this kind of urgency to get this stuff out there. in part to correct the wrongs of the past, which I fully support and appreciate. I do think that we as a culture can develop an adult relationship with this in much the same way we have with cannabis. So, 25 years ago in the US, cannabis was still this largely prohibited substance. A lot of people went to jail for it. People still go to jail for it, particularly people of color, particularly marginalized communities. It's often used as this kind of cudgel to uh, to harm people with with legal repercussions. But I think in the last, now I turn on my social media and I'm getting ads, for cannabis, and not just CBD. I'm seeing THC and Delta 9 and Delta 8 and Delta 10 THC being sold, in social media ads. So, clearly we've come to a different relationship with that. And I think we can do the same thing with psychedelics, but it's very early days still.
Yeah, no, I hear you. So what about these retreats, so to speak? You've got famous ones like Burning Man and some others where I'm sure there's lots of psychedelics being used. It's being done.
Mhm.
People go to them. Like how, and they exist. So how does someone, I guess, vet that?
So I'm full disclosure. I've been going to Burning Man since 1998, so I know a thing or two about this.
It's
Um,
on my list, so I'll let you know when I go and see if you can give me some tips. But go ahead.
Absolutely. I wouldn't say Burning Man is a psychedelic retreat. I think it's much more than
Yeah,
that.
of
So
course, of
there are
course.
there are there are definitely places that are offering psychedelic specific retreats. And sometimes they are out of the country where these things are legal or decriminalized. Sometimes they are in underground kind of settings within the U.S. where people are doing this in spite of the law. Um, and it's very much buyer beware. I think is the best thing I can say about that, is that these are largely unregulated for the most part, and so you're very much it's very much going to be dependent on the skill and the ethics of the people running the retreat. And I think there's a lot of people sort of rushing into this space because there's a lot of market interest. That doesn't always make for a very high quality experience. And setting quality aside, we need to think about safety too, because there certainly have been reports of people being harmed, either through sexual abuse or financially harmed and such. So it's a very early stage of this process, and
Mhm.
there's a lot of promise. There isn't necessarily a lot of regulation around this. One thing I will put a plug in here for is something called harm reduction, and harm reduction as a public policy really seeks to it acknowledges that human beings use drugs. We have since before recorded history. Really, there's evidence of say psilocybin use that goes back 6,000 years. So we've had long-standing relationship with these, usually held with great reverence. These were not intoxicants; these were sacraments, and they were used by people to access spiritual uh, a spiritual experience, if you will, religious experience, or in many indigenous cultures, these are very much a part of the fabric of the culture. And so outside of those settings, harm reduction says since we know that people do this, let's try and reduce the amount of attendant harm that goes along with this. So, for example, at Burning Man, where there, like any large gathering of people, you're going to have some degree of substance use, and psychedelics can certainly be a part of that. There's a organization that I've worked with in the past called Zendo, the Zendo Project, which sets up a safe, comfortable place for people, staffed by kind, uh, trained volunteers who will sit with somebody while if they are having a difficult psychedelic experience, or perhaps maybe they had one earlier in the week that they want to talk about, that is a place where they can do that, safe and protected. And we know that these compounds have a duration of action which will wear off, and after it wears off, most people return to a normal state of consciousness. But it can help to have somebody kind of support that. And outside of Burning Man, there's something called the Fireside Project, the firesideproject.org. They have a phone number, I think it's 62 Fireside, where trained volunteers can help somebody who's having a challenging experience with or following a psychedelic experience, or provide information about psychedelics. And so these are ways of sort of mitigating potential harms that I think are really important, and things that we need to scale up in the larger culture if we're going to have a space for psychedelics that is safe and thoughtful.
Okay, interesting. So you mentioned that you're looking at bipolar 2. I have a particular interest in this because, and Lynn Marie and I were talking, I was like, should I say this? She's like, well, when you share, that's when you open the door for others to feel comfortable. So I will share. So I have bipolar 2, and it sucks, like really bad. I have to like monitor so many things. Like the biggest one is sleep. Like what time I go to bed, how much sleep I get. And sometimes I can't control it because I've hit menopause. And so it's just like all these layers. And, I actually had done an episode on cannabis, and someone sent some to me, and I tried it. And I don't know if it was COVID, perimenopause, having my son and no one around to help during COVID, or if it was the cannabis. I went nuts, and I was like, I am not touching this. It sat on my shelf and expired. And so I think about like this study. And so one, I'm like, how in the world do you do it? What is the risk? Like, can someone have a psychiatric break? Because I've been on all sides of the stream of mental health having this. And so I'm so curious about like the precautions, what you're seeing that you're allowed to share. Like, how would someone in these states where it's like, I would so want a solution, but I also see when it's bad, it's scary, that I'm like, no way. So I'd love to hear about that.
Yeah, for sure. Yeah, for your listeners, it might be worth just briefly differentiating out these different bipolar numbers.
Please.
What do they mean?
Yep.
So, when bipolar disorder is historically something called manic depression, and bipolar 1 disorder is where people have periods of depression, and they also have periods of what we call full mania. So in full mania, somebody for many days at a time, often sometimes several weeks at a time, will have periods of very elevated energy. Sometimes it can have kind of a euphoric or grandiose quality. People get lots of ideas, and they'll often be talking very fast. They might sleep an hour a day, maybe even not sleep at all. And after a while, it really starts to, people's judgment becomes impaired. They can become impulsive, and it often ends with a really rough depression, which can go on much longer than the manic episodes. So these manic episodes are usually kind of infrequent visitors, but people spend a lot of time being depressed. So that's bipolar 1. Bipolar 2, which you're talking about, Georgie, is where it's really a condition of chronic depression with kind of a cyclical quality. So the depression will kind of come and go, and we differentiate this from depression, in which is sort of a response to outside events. So people with bipolar disorder often they'll fall into a depression, and they'll have no idea as to why. Because it's not reacting to something in the outside world. It's more a reflection of their internal biology. And they spend a lot of time being depressed. And the reason it's not just called major depression, which is what most people think of when they think of depression, is because of these periods. So there's a cyclical pattern to it, but then there are these brief periods of what we call hypomania. And hypomania is where somebody for maybe a day or two has an increase of energy, maybe a week, an increase of energy, but it's often not very pleasant. It often can feel kind of restless and agitated and anxious. Am I describing this accurately?
Yes.
Georgie? Okay.
Yes.
You're not able to sleep, but you're exhausted. It's kind of wired but tired. It's not a good feeling at all. There's not a lot of enjoyment in those periods at all. And so the reason why we've been cautious in the trials to date around bipolar disorder is that there are case reports. I've written one that's in the literature myself, that of people getting either having mania or having psychosis type symptoms. So when I say psychosis, feeling paranoid, feeling like maybe things aren't real, feeling like people are trying to harm you, those sort of distortions of reality, if you will, consensual reality. And there are reports of people with bipolar disorder having these episodes elicited by psilocybin and other psychedelics. And so when you start doing clinical trials, you're exceedingly cautious in who you allow into the trials in order to maximize safety. And then as you begin to develop some knowledge base around for whom this is safe and whom it's not safe, which is just as important as knowing for whom it is safe, is knowing who can be harmed by a treatment, is then you can start to kind of work on those edges, right? And so the reason why we chose bipolar 2 instead of bipolar 1 is that we want to make sure that we don't make people worse, is really the short answer. Ideally, we want to help people feel better. So in a pilot study, which is what we're doing, you don't have a placebo control. So we know what we're giving everyone. Everyone knows what they're getting. And we're looking more at the safety signal than the efficacy. We'll look at both, but really the first question to answer is, can we do this with a small number of people without making them worse? And we're very early in the study, so we haven't actually analyzed the data yet, but it'll be interesting to see if we can do this safely. So that's the question that we're working on right now. And if we can do it safely, then that creates a sort of foundation of evidence that we can then go on to do larger studies with more people, maybe with a placebo control, to try and control for some of those expectancy effects that we talked about around Michael Pollan, and then really start to see if this can be something that helps. So, these sort of insights help people understand, like, why does this take so long? This is why.
Yeah, no, it's true. And I hope you find something, because you're right. It's like I even talked to my therapist, and I'm like, today I'm like on it. And so this is the day where I am like tackling my list, because I
Yeah.
don't know how long it's going to last.
Right.
And I'm still very productive. Luckily I've never like sat down and like had to like crawl into bed for 3 days. I've never been like that, but I'll struggle to like do things the way I normally do. And
Yeah.
I used to never be like this. And so it's incredibly irritating, because I
Yeah.
literally have no idea. So I'm like, control sleep, control what I eat, and I hope for the best each and
Yeah.
every day.
Yeah. No, it's, and you're certainly not alone in that. And I think for people that struggle with that, or any really, kind of chronic episodic illness, which affects your ability to function, part of the burden of that is that unpredictability.
Yeah.
What's tomorrow going to bring? I don't know. Will I
Yeah.
be able to do these things that I planned tomorrow? I don't know. We'll see what tomorrow brings. But it definitely is part of the challenge, for sure.
Yeah, no, it's irritating. So then let me ask you this, because I was kind of alluding to it when I was giving my story about, I don't really know why, when I tried the cannabis, it affected me. So, with women, it's additionally complicated because of our hormones. And I'm curious, do you have either anecdotal or data, anecdotal evidence or data around menstrual cycle timing or even phase of life? Because, like, for example, when a woman is in perimenopause, within a given day, the hormones are all over the place, much less over a given menstrual cycle, however long that menstrual cycle chooses to be at that point in time.
Right.
And then obviously when there's all these added layers, like now a lot of women are undergoing fertility treatments, you're given additional hormones. So there's all these like hormone related activities that are happening. Like Lynn Marie even said, is there a certain time of the month where if someone
Right.
is on a regular cycle, it's better to give it than not? So what do we know so far about that?
I think the short answer is not enough, not a lot, not enough. And some of that is, it's not willful neglect. I think it's just a artifact of the relatively small sizes of these studies so far, and that most of these studies are focused primarily on creating the evidence that would be necessary for getting this to the FDA and having FDA approval. Once you have that approval, it becomes a lot easier to do studies of different populations, right? And so, if we were to look at something, so one of the larger studies that was done recently, there's been two what we call phase 2 studies of psilocybin for major depression. The one I worked on, I think we had 108 subjects, something like that, and the one that was done in the UK had a little over 200. So if we say, roughly half that population is identified female at birth, we've got 100 people or 50 people, and where that question of where they are hormonally at any given moment is another large variable. And so this is definitely data that we need to start looking at. I think it's definitely needed to understand this, because we know that women, for example, experience some mental illnesses such as anxiety and depression and PTSD disproportionately to males. And so that's one big challenge, and one area that we, this is another underscoring why we need better treatments for these conditions, is that women suffer from them disproportionately, and we need better treatments. And we also know that biologically there are these closely tied relationships, say, between estrogen and mood, progesterone and mood, serotonin and estrogen tend to kind of track each other, and so there are these fairly predictable mood experiences that people have in the premenstrual phase, for example, or postpartum. And so there's a huge need for this, for sure. And then understanding, there was I do believe in the MDMA study phase 3 that female sex did predict a better outcome for people that were randomized to the MDMA group. Not sure what to make of that, but that I think is encouraging news, especially given that women are over twice as likely to experience PTSD in their lives. So, and then there's a whole nother subset of understanding that we need to gather around transgender patients, and how does hormone replacement therapy impact the effects of these, and should we be thinking around timing? I think your point is well taken, that the effects of these may be attenuated by where somebody is in their menstrual cycle. There is Natalie Gukasian at Hopkins did an interesting case series of 3 women talking about changes in their menstrual cycle following psychedelics. And so there may very well be a signal there, but we are really just in very early days with this. There's I kind of feel like we're it's like those 17th century maps of exploration, where there would be sort of the known world, and then there's sort of this fuzzy edge where we know there's something there, we just don't know what it is.
Right.
Yeah, and it's not. I don't think we've been sort of willfully ignoring these things. It's just a lot of this research is done on a shoestring. Most medical research in this country is done with federal funding. Most all psychedelic therapy research has been done with private funding, and that's challenging. So that creates a whole other set of challenges. And so we need better funding to do the research, so we can really begin to explore these questions
Right.
on a large scale.
Right. No, thank you for sharing that. And I will just say, since you are in this space, and for anyone, who is listening, what I would love to see, not just with psychedelics, but with everything, is, I've had experts say to me, we need to separate out even women who are on birth control versus not.
Yeah.
People are not talking about that enough. We need to look at what stage of life are they in? Is it reproductive years? Is it perimenopause years? Are they postmenopausal? And, just a lot of different factors. And I know it's harder, more expensive, and takes longer for women, but they're half of our population. And so it's funny. I'm like, where should I be focusing my energy? I'm like, maybe influencing clinical trials.
Yeah. And and I think there are reasons to be hopeful around this.
Yes, of course.
So psychedelic therapies could be included under a broader umbrella of what we might call rapidly acting antidepressants. Um, and so this would also include things such as ketamine, but also, a drug called zuranolone, which is an oral version of a drug called brexanolone, which was FDA approved maybe about 4 or 5 years ago. Which brexanolone was an IV infusion, rather kind of cumbersome to give and to obtain for postpartum depression. But zuranolone recently was given FDA approval as a treatment for postpartum depression. And it's not an SSRI. It works on something called GABA receptors, and it has a rapidly acting antidepressant effect. And so that is, I think things such as that are really promising, because postpartum depression has really been an area that we don't, like many areas of mental health, we don't have treatments that are as rapidly acting and as robust as we would like.
Yeah, no, I agree. So I'm curious, in the recent trial where the PPD drug was approved, I'm curious if you had any thoughts based on your research and experience with these different mental health conditions about why perhaps the major depressive disorder wasn't approved, but postpartum depression was. Um,
Yeah.
yeah, I was curious if you just had any hypothetical reasons for that. I'm just so curious.
Yeah, I don't, unfortunately. So, just the backstory for those who are unfamiliar. So, zuranolone was simultaneously being investigated for both postpartum depression, but also major depression. So not necessarily related to childbirth, and it did not succeed in the major depression study, whereas it did in the postpartum depression study. So the FDA approved it for postpartum depression, but not for major depression. It's difficult to know. It may be that that the hormonal changes that are attendant to postpartum depression were better addressed with this drug, which is essentially a version of allopregnanolone, and that may have been why it was more robust. I mean, I think I'm just really kind of engaging in a lot of speculation here, but unfortunately, the data did not support that it worked in major depression.
Mm-hmm.
That may be an artifact of the way the study was designed. Sometimes when you have these sort of disappointing results, you go back to the drawing board and you say, okay, did we do something wrong here? Was the dose insufficient? Was the treatment not long enough? Do we need to look at those kind of things? Do we need to, you start looking at various populations in your study and see if one group did better than another. So sometimes you see a sex difference in the data, and so those would, I think, all be the things that you go back and look at after study is unsuccessful, to see if there's some signal there as to for whom it might be helpful for, because in aggregate it might not be helpful, but maybe for a particular population it's helpful.
Yeah, no, I was thinking that as well, because just knowing what I know about postpartum depression, and then understanding what I do about major depressive disorder, I would think a lot of it. I mean, again, I'm not saying the drug would be effective if they redid the design, but I am so curious if it's just the manifestation of each of those, and how it could be easier to see results for postpartum depression, just given how it manifests. And if you address it earlier, it kind of evens out. And so that could have been why it was easier, supposedly, or so to speak, to show results. So we'll see. It'll be interesting to see what happens in the near term with that. So are there any known contraindications for psychedelic use that people should be aware of? So we know we talked about bipolar 2, it's being studied, or for bipolar generally. But what about any other known contraindications, which is, hey, I heard this, I'm fascinated, I'm going to one of these retreats, or I have a place where I know to use it safely, and I know XYZ about myself, therefore I definitely should not be using it. Like who would that be?
Yeah, well, I don't want to give medical advice to people that I don't know, but I can tell you some of the things that we exclude in our studies. Definitely people that have a personal history of any psychotic illness. So somebody who's had a history of schizophrenia or bipolar one, particularly with psychosis, or has a first degree relative so a mom, dad, brother, or sister with um, psychosis in any form, we would be very cautious about and often exclude. So, that's because there is a genetic component to many of these conditions, and sometimes people can have some of the genes which are associated for risk for that condition, and so we'd be very careful around that. The other area where we're very cautious around is people with cardiovascular disorders. So things such as psilocybin and MDMA do cause transient increases in blood pressure and heart rate when the drugs are in effect, and so we're very careful with people that have uncontrolled high blood pressure, or have congestive heart failure, uh, have arrhythmias, cardiac arrhythmias, have heart valve problems. Those are other areas. And then the other thing that we control for in these studies is that in many studies, medications are discontinued, and sometimes that's because they directly interfere with the effects of the drug. So, for example, we haven't got too much into the weeds of the neurobiology here, but classical psychedelics, which is sometimes referred to as LSD, psilocybin, DMT, which is the active ingredient in ayahuasca, those have part of their effects are mitigated by something called the serotonin 2A receptor, and so a drug that blocks the serotonin 2A receptor, so something such as like trazodone or a whole class of medications called atypical antipsychotics. So this includes things like Seroquel, Zyprexa, Risperidone. Those all block the serotonin 2A receptor and would likely mitigate the effects of a psychedelic that works on serotonin 2A. So it would probably dampen the effects of that. There are other drugs that we that are contraindicated, which means that we take people off them before they ingest the drug for safety reasons. The most important one probably in that area would be most antidepressants should not be combined with something called ayahuasca. So ayahuasca is a brew that originates from the Amazon, and it contains at least two different plants, one of which contains the drug dimethyltryptamine or DMT, and the other contains something called an MAO inhibitor. And so MAO is an enzyme that breaks down things like serotonin and norepinephrine, dopamine in your body. And the reason why this brew has both the psychoactive plant and the MAO inhibiting plant is to prevent the ayahuasca from being broken down in the DMT in the ayahuasca from being broken down in the gut before it has a chance to get to the brain. But that creates a potential risk for something called serotonin syndrome if they're taken with an antidepressant that works on serotonin, like a Prozac, Lexapro, Zoloft, something like that. And so generally people need to be off of those medications for some time, and that varies from medication to medication depending on how long the med stays in your body generally, for some period of time before they were to ingest ayahuasca. That's a really important safety precaution.
Wow. So what is serotonin syndrome?
Serotonin syndrome is essentially when you have too much serotonergic activity, serotonin activity in your central nervous system. And so it can manifest in the form of like jaw clenching, teeth grinding, shivering, difficulty monitoring your body temperature, which is the big risky thing here is that people can get hyperthermic, something called malignant hyperthermia, where people's body temperature gets very hot, and they have difficulty cooling it down. Serotonin syndrome can result in seizures. It can actually be life threatening. So it's something that you have to be careful with, particularly with these drugs that work on serotonin. And you can see serotonin syndrome like symptoms in people that use excessive amounts of MDMA in one setting. That's a known risk with MDMA. It can also disrupt things such as your sodium levels in your blood, which can lead to swelling in the brain. No, these are uncommon side effects, to be clear, but it's also one of the reasons why, back in the old rave days, there were issues with hyperthermia because people were often dancing in hot settings. We don't see that happening in our clinical trials because we're monitoring people's temperature, so that doesn't seem to happen when people are not ingesting this in a hot environment and then exercising in the form of dancing. But one of the things that was sometimes happened back then is people would drink excessive amounts of water, which can lead to something called hyponatremia, which is where you sort of flush out a lot of the sodium in your bloodstream, and that causes all sorts of disruptions, including swelling in the brain. So, while people you certainly want to remain hydrated under something like MDMA, you shouldn't be drinking gallons and gallons of water. That's not good practice.
Okay, good to know. Thank you. So, I guess one, I would love to summarize like what people who are curious should do if they're truly interested, and then I want to conclude with like what you're excited about in the near future. So, we've had a cautionary tale in this discussion. It hasn't been psychedelics are the best thing around. Everyone should be on them all the time. Forget pharmaceutical medications. And I really appreciate that because I do think with the way media, clickbait, all these things, people, I think, take things to a certain level. And look, I'm one who will try anything. But even I'm listening, I've interviewed 3 experts now, and I'm like, wow, I'm kind of sold on being really careful.
Yeah.
But, I would love to know your thoughts. And I'm asking everyone, like, what do we do in the meantime? So I am someone who is curious about psychedelics, and I really want to give it a try. Like, what would you, not knowing that you're not their doctor, what would you, I guess, suggest for people to do or research or know on their path to figuring out if they should do this and where to go?
Yeah. I think there's sort of a both and answer to that question, right? So, I'm obviously very interested in psychedelics. I spend a lot of my waking hours thinking about it, talking about it, and writing about it. So I wouldn't do that if I didn't think there was promise. That said, I want this to succeed, and I want to follow the data. And the thing about science is that you have to follow the data no matter where it takes you, even if it's not where you thought it was going to take you, or if you're disappointed by it. So, in sort of descending order of probably safety and containment, the more difficult way to have one of these experiences, but probably the safest way to have one of these experiences, is to enroll in a clinical trial, because it's important to remember that, with the exception of ketamine, which we haven't really talked about, but certainly can have very psychedelic-like effects and is also a rapidly acting antidepressant drug. That the compounds we're talking about today, MDMA, psilocybin, LSD, these are all Schedule 1 drugs. So they are, as of right now, federally illegal to possess or use. And so the only place where that can be done legally is in a clinical trial. The best way to find clinical trials for anything is something called clinicaltrials.gov. This is a government-sponsored website. It's not sponsored by a drug company. It's just National Institutes of Health. And it is a directory of all clinical trials. It's as simple to use as Google. You could type in there depression and psilocybin, and it will show you all the trials that are going on right now, that are about to start, or that you can filter the results by geography, and at least gives you an idea of if there are studies going on that might be of interest to you. So that's probably the safest way to do it. Now some states like Oregon are developing these, what they call adult access programs, adult use programs. So supervised use, not necessarily for a clinical indication. In fact, in Oregon, they specifically cannot say that they're going to treat your depression. So you go to one of these experiences, and it's kind of like, I guess, like going to a yoga retreat, right? You don't need a doctor's prescription to go to a yoga retreat, and your work there is largely self-directed. And so a place like Oregon has passed a law that allows for adults to have a psilocybin experience in a supervised setting, which they unpoetically call a psilocybin service center. Um, but that's so that is available to adults going to the state of Oregon. Colorado is also in the middle of a bill that will allow some degree of access, and many states and local areas are starting to kind of dip the toes in the water of various forms of either adult access or decriminalization. And then there are other countries where this is available, Jamaica, Mexico, Peru, Holland, where there is some form of legal access. And as I mentioned before, the those kind of settings vary considerably. So, I would really strongly suggest somebody do their research before and talk to people who have been to those settings before going into that. And also understand that we can't necessarily say with certainty at this point that we can replicate these clinical findings in these non-clinical trial settings. So if somebody says, well, you can go to Oregon and take psilocybin for your depression and it'll work just as well as what we're doing at UCSF or at Johns Hopkins, we don't have evidence to support that as of right now. We haven't done that study. It's a study that really needs to be done. We have seen from survey data that people that use psychedelics in a what we call naturalistic setting or maybe recreational self-directed setting, often do report they self-report benefit, and they also report a small portion of harm. So these are not without some degree of risk, but the vast majority of people report some benefit from them as well. So that has always been and probably will forevermore be one route that people experience psychedelics. And they certainly, people are within their rights to do that. It's just a little less predictable perhaps, but if they are going to do that, to really be thoughtful about how, where, and with whom they do that, to have a place set up where you are away from the distractions of the everyday world. You do not want to be looking at your phone notifications while on a high dose of psilocybin. You don't want to be in a place where you could fall down and get hurt in that state, because you may not be fully attuned to your body. You ideally want somebody there who can be with you and keep an eye on you and reassure you if you get scared. So these are all sort of harm reduction measures that people can think about, if they are going to pursue this sort of thing on their own, to be really thoughtful about how they do it. That while certainly many people have had delightful experiences at a concert or Burning Man or something like that, people also have really challenging experiences out there too. Anybody who's worked at a place like Zendo or RockMed at a concert, knows that people have challenging experiences. It can be very just sensorily overwhelming to be in a concert with lots of people, lots of noise, lots of lights. When you're when your brain and your emotions are in a very raw place. And the thing with psychedelics, there's kind of an old adage that you don't always get the trip you want, but you get the trip you need.
Yep.
And somebody who goes to some place like Coachella, and decides to enhance their music experience with a psychedelic, may get that experience. They might also end up thinking about when their mom died when they were 10 years old. And that's going to be a very different experience. And it's not to say that thinking about when your mom died when you were 10, it can't be, is necessarily harmful. But Coachella might not be the spot where you want to have that experience.
Yeah. Yeah. No, great. Thank you. No, thank you for sharing the facts and not the fantasy of psychedelics. So I think it's important to know these things. And, I don't do this podcast to, get TikTok views. I do this to get the facts out that people sometimes don't want to hear. So there you go.
Well, I hope I'm not too much of a wet blanket. I sometimes joke that I feel like a bit of a Cassandra, but I think it's really important to just to be considered about these things, and that one can be considered and be anti-prohibitionist.
Yes.
I think those two things can exist at the same time, and I don't think we've made enough room for people doing that in the psychedelic space.
Yeah, no, I agree. So what are you excited about in the near future? Like what's What are you hopeful for and excited about?
I'm really excited to see the end of so MAPS will soon be submitting something called an NDA, a new drug application, to the FDA for the approval of MDMA assisted therapy for PTSD, and assuming that is approved, that's when things are going to get really interesting, right? So, and really
Nice.
complicated, because we don't really have a healthcare system that's set up for this right now. I mean, we barely have a healthcare system that's functioning as it is. So, to add this layer of complexity is going to create some brand new challenges, which I think create exciting opportunities, but also are going to be challenging to navigate. But I'm really excited at the idea that, you know, I'll share with you a story. So when last time I had to take antibiotics, some crud, I don't remember what it was, but I remember like a day and a half later feeling like myself again. And I thought, damn, I wish the meds I prescribe for people for psychiatric conditions worked this well, right? So the idea of actually, I've been working in mental health for 30 years, and I've seen a lot of people who I have great admiration for, who are really struggling, and I really would love as a clinician to be able to offer more robust treatments that actually work better and that sustain that benefit over time, and that help people develop a different relationship with these parts of themselves that are, that have depression, that have anxiety, that have trauma, that maybe, what we're doing here is not necessarily eliminating those things. It's not this kind of, like we're going to cut that out of you sort of idea, but that you develop a different relationship with that aspect of yourself in a way that reduces the amount of suffering. And I think that's something that's so important. I'm also really excited as a nurse to see how nursing is going to play a central role in this. I mean, I think nurses bring to this work a sort of a natural skill set and a native sensibility for sitting with people, for making room for healing. That's really excited. I co-founded an organization called the Organization for Psychedelic and Entheogenic Nurses, Open Nurses, and I think nurses are going to be a really important part of delivering this care and also scaling it. Because one of the challenges we're going to have is we don't have enough clinicians to deliver this therapy who've been trained in this. And so I have a vision where many nurses learn how to do this work and can sit with people while they go through these experiences, keep them safe and help them heal. So that's something I'm really excited about. So there's a lot to be excited about. While
That's
I may have
awesome.
brought a little bit of the wet blanket in, I really hope that I haven't obscured the idea that there's a lot to be hopeful here.
No, absolutely. And I got emotional when you were talking about the antibiotic experience. Like, um, yeah, I mean, I feel fortunate. I have a great support system. And I'm very open about things. And I just keep hearing when you're open, that's when like the truth of from everyone else starts to come out. And so it's been, but I can't even imagine for those who have like they're really alone in this. It's really hard.
Yeah, for
So I
sure.
have that hope as well. And I did read about the nurses program that you've started, and it sounds wonderful. And I agree. Jordana and Jacqueline and I, which will be the first episode in this series, we talked about, okay, so now we have these approvals. Now what?
Now what?
So
Yeah,
yeah, so
absolutely.
it's a really interesting time to be in this space, and
It really
hard
is.
but interesting problems to solve for sure.
Yeah, and it's also, I just want to also put a call out here too, that I know that your podcast is really focused on women's health, and that while the face of psychedelics in the current era has been a little too male and a little too white, for my tastes, and I'm clearly part of that problem. Um, that the history of psychedelics is, and the history of plant medicines in general, for which some psychedelics derive from, is really one that was largely occupied by women through much of history, and the people who have carried this knowledge forward and endured a lot of persecution for doing so have largely been women. And so, I think it's just worth acknowledging that debt of gratitude that we will all, if we are successful in this, that we will owe to those women who have very bravely carried this forward for generations.
Oh, thank you. Maybe there'll be a documentary on that, because now you see all these documentaries where they're bringing forth like, oh, there's actually all these women behind the scenes that helped with all these grand moments in the world. So
Well, I'll tell you a
thank you for
story.
acknowledging that, please.
In next year, I'm hoping to go to Saskatchewan, Canada, because there is a nurse there named Kay Parley who worked with a psychiatrist back in the late 1950s, early 1960s, a guy named Humphrey Osmond. Humphrey Osmond did many things, but one of the things that he also did was coin the term psychedelic, along with his friend Aldous Huxley. And so Kay Parley worked in a large state psychiatric hospital there in Saskatchewan, Canada, using LSD with patients who had alcohol use disorder in the early 1950s and beginning of the 1960s, well before this ever became known to the youth movement and Timothy Leary and all the stuff that happened later. There's a period of history starting with the synthesis of LSD in 1938, going up until 1970 when the Controlled Substance Act was written, of research similar to what we're doing now. Perhaps not as rigorous as the research we're doing now, but there was a lot of interest and a lot of what you might call sort of above ground scientific work looking at this. And so Kay Parley, she is now 100 years old. Every time we correspond, she reminds me that she says, well, I am a limited time offer. But I've spoken to her on Zoom, and she's sharp as a tack and has some amazing stories to tell about this. So yeah, we want to contribute to the history of this, that focusing some of these women that my friend and colleague Maria Mangini highlighted in a really fantastic paper called Unseen Women in Psychedelic History, which I can't recommend highly enough.
I'm making a note. I'll put it in the show notes.
Yeah, and she talks about Kay Parley and a number of other women who have been really instrumental in holding this, but don't always get the recognition that they deserve.
Right. And wasn't LSD even discovered in a lab with the scientists from Sandoz was actually trying to discover something for postpartum?
Well, not for postpartum.
Mistaken?
Yeah. So the interesting thing, if you indulge me in this for a second, is that
Please.
So LSD was derived from ergotamine, which is a fungus that grows on rye and other grains. And interesting thing is that midwives have known about ergotamine for centuries, because ergotamine was used as a uterine tonic, so it causes the uterus to contract. And so it was used by midwives in so quickening of labor, so people that were struggling to labor, and also in postpartum hemorrhage to get the uterus to clamp down and cut off the bleeding from where the placenta detaches. And Sandoz was looking at this as a possibility, or ergotamines as a possibility, as for something they called analeptic. And analeptic was a drug it was a respiratory and cardiac stimulant that you would give to people maybe as they were coming out of anesthesia, which, if you remember, it was a fairly new invention. Thank God for anesthesia, but we didn't really have anesthesia until the turn of the 18th century, 1800s into the 1900s. And also to reverse barbiturate overdoses. So barbiturates, which were the previous drug before benzodiazepines, were much more dangerous in overdose. It's probably a barbiturate overdose that caused Marilyn Monroe's death, for example. And so this idea of developing a drug that would keep people breathing and their heart beating if they were in an overdose situation was the other thing that they were interested in developing. They had no idea it had these psychoactive effects that it does. And as the story goes, that Albert Hoffman, who was the chemist working on this, accidentally ingested some tiny amount, on his fingertips, probably touched his mouth, and thought he'd poisoned himself, actually. And it was actually his young lab assistant, Susie Ramstein, who got him home on a bicycle. That's where the expression bicycle day comes from. It's an acknowledgement of the day that LSD was discovered to have psychoactive effects.
No way.
She got him home.
I hadn't heard that yet.
It was 1943, so it was the middle of the war, and in Basel, Switzerland, and they didn't have gasoline was rationed, so they were on bicycles. So they got home on their bicycles. He asked that she call his doctor, who examined him and found there's nothing physiologically wrong with him other than his pupils were very dilated. But he went on to have this rather fantastical experience that I think he was frankly partially quite scared of. He didn't quite know what he stumbled into. But after that, Sandoz sort of had a solution looking for a problem, and they started to try it through sort of crowdsourcing, if you will, to ask psychiatrists to if they wanted to work with it and to report back what they discovered. And so that's how we got LSD, which is really a wild accidental discovery. Like a lot of things in science, science is often a series of happy accidents, So, and the things we thought we knew back then, turned out to be quite embarrassing in the future. But,
Yes,
and I'm sure there will be mistakes we're making now that we will sort out in the future.
I am sure. Thank you so much for making time and for your dedication and for, giving us the truth about this, because we want people to be safe. And look, I'm all for trying new things, but we want to make sure that we tread with caution when necessary. So thank you so much for sharing the facts and your perspective.
Thanks for having me, Georgie. I appreciate it and enjoyed our talk.
All right. Take care.
All right. Bye now.